pseudo guest today. Not so much a guest, but Scotte Hartronft is certainly one of us, but is also interviewing as a candidate for the Associate Chief of Staff for Geriatrics and Extended Care position. And so he's going to be giving us a talk today on one of his areas of interest, behavioral and psychological aspects of dementia. And you all know Scotte's background as well as I do, but he's, I don't know if he's born in Oklahoma, but he's bred in Oklahoma and certainly educated there. Got his MD degree at OU, I guess, the University of Oklahoma. And actually had a nursing career before his medical career. And did his residency training in internal medicine at BAMC, and then went off to a geriatric fellowship in American Lake in affiliation with University of Washington. Then back here to the military until we were lucky enough to recruit him last summer. So, Scotte, thanks for your willingness to give a talk, and it's fun to have discussions with you in sort of a formal setting. It's sort of interesting. And thank you all for participating in the interview process. So thanks.
Cool. Thank you, sir. Would somebody? Would you mind?
Yes.
I'm sorry. I didn't mean you, sir. Thank you. Okay. First of all, again, as he introduced me, everyone pretty well knows me. I'm Scotte Hartronft. And today I'm talking about a subject that's usually not talked about very often because it's not got enough evidence to really become evidence-based, and a lot of products are off-label. So I wanted to choose a subject that wasn't necessarily a traditional safe subject, but open one for discussion and definitely one for interactive conversation, because I think it's a very big topic for any of our fellows that I knew would be attending, that they would be dealing with in many aspects. So again, just remember, I have to say this for the CME credits, that these are many off-label indications in this talk. So I want to be that up front. Let's see. First of all, why are the behavioral and psychological aspects of dementia important? Well, if you really start at a quality of life perspective for patients, it's actually rated as one of the most stressful aspects for caregivers. And a lot of times it also is the primary factor for whether a family can keep a member at home or not, or if they have to be institutionalized. So it's actually a very significant factor in a patient's lives with this illness. It also increases the hospitalizations due to falls. If someone's agitated or aggressive or manic or psychotic, then they have to be admitted. And also, again, the big thing is the quality of life, both for the patient and for the family. So that's why we're really tackling this topic. Now, the instance, it's across all dementias. It occurs at some point in the disease in 60 to 98% of patients with dementias. And Alzheimer's specifically, psychosis is common in 41% of the patients. Breaking that down into delusions is prevalent as 36%, and hallucinations in 18%. And then when you start talking about Parkinson's patients with dementia, whether it be more of a Lewy body-based etiology versus a dementia patient that has concomitant or comorbid dementia of any other type, psychosis is 20 to 40%, but they have a higher rate of mood fluctuations with Parkinson's patients with dementias, and also a very common depression in 40 to 45%, especially early on in the disease. So for quality of life purposes, it's very important to be open to these patients being prone to having these conditions. Now, definitions of behavioral disturbance are very important in that you need to realize that it's not just if it aggravates the staff necessarily taking care of them. It really needs to be a behavior that puts the patient or others at risk. Would it be better for me to stand? Can everyone see all right? Just want to make sure. So it's actually, and also a behavior that makes keeping the patient in milieu difficult for either the staff or other patients. So it's not necessarily that it requires staffing issues in the sense that it takes a lot of time for the nurse or another person to keep care of a wandering patient, to say, as an example. Whereas it's really, you want to focus on behaviors that really place someone at risk, because these medications do have side effects. one of the things we forget, just like with delirium, we also want to look if there's an underlying etiology for this. And that is ultimately the treatment, not just treating the symptom itself. So the 6 I's for mnemonic is iatrogenic. You want to look at have you put them on any medications with high anticholinergic side effects? And even some of the sedative hypnotics are known to cause behavioral changes. And also you want to look for infection, because these are the patients that may not be able to tell you the typical symptoms of an infection. So these are the most prone patients and also the least able to tell you the traditional symptoms, and aren't going to come and tell you they have burning or they're having trouble breathing. So you've got to look for the traditional things that we notice in geriatrics with UTI, pneumonia, but also one of the more common ones that are being seen in chronic that we haven't really been looking for in the past, dental problems and infections. Injury, you've got to look for hip. I mean, did this patient fall the night before and now suddenly they're having outward behavior? Is this their expression of pain? So you've got to realize that their expression of any of these type of etiologies are not going to be as the normal patient. Illness exacerbation, whether it be diabetes, COPD, major depressive disorder, GERD, or angina may also be, this may be their anginal equivalent, at least in their perspective, to be able to communicate that to you. And then you also, as usual, you want to make sure they're not, don't have an impaction, and also things such as inconsistency in the environment, such as a change in the routine, whether it be caregivers, whether they were moved to another room, whether temporarily, whether their roommate has changed. So you really got to look at what's causing this and not just simply going to a treatment for a symptom. And then there's multiple others. You want to make sure that they're not thirsty, hungry, and then little things, well, we say little things, but if you live there in a room all day and you hear a door slamming constantly, especially if someone has dementia, that's going to be not only aggravating but also a potential for them acting out, because it adds more confusion to their baseline. And key also sleep deprivation. So again, you got to remember and look for causes and not just simply treat the symptoms. Just again, I use delirium as also the other equivalent to needing to look for etiologies. Now the therapies for behavioral, we want to again look at the etiology and treat that, because ultimately that's going to be the treatment. And then you want to identify the target symptoms. Are they mostly depressed? Are they aggressive? Are they agitated? And then you want to treat those appropriately. But you also want to start off with behavioral and environmental approaches, which a lot of folks, that drives them nuts because that is resource intensive at times, but also it does prevent requiring other medications, whether it be distraction methods, whether it be a change in the environment, or other issues. Now, one of the things you want to do is find kind of the overall symptom that they're having. Is it more of a depression component, more of a psychosis, mania, aggression, or is it more of a disinhibition? Because you may treat them a little differently, as well as how quickly you're going to start treating them with a medication versus environmental or behavioral therapies. Define your objectives. First of all, of course, you want to make the behavior go away, but you also want to treat the underlying cause, improve patient outcomes. And one thing I wanted to talk with, especially since fellows were going to be here, is OBRA guidelines in long-term care. This is something you're going to have to live with, know it, understand it, and be conversant with it. And also, ultimately, you want to restore calm and safety to the situation and the unit. So again, one patient acting out is not just that one patient at risk, that can place many patients as well as staff members at risk. So I like to do this up front and let you know that, kind of give you an overall approach before I kind of get into the meat of the topic, because you want to identify the target symptoms. You both want to evaluate it for causes and etiologies. You also want to decide, basically, is it more of a depressive or is it more of an agitated psychomotor type disturbance? And then you want to evaluate, again, more of a non-pharmacologic approach. If it's simply someone being moved or their environment changed, by all means do that first. And then if their symptoms are relieved, you want to monitor and reassess. If it isn't, then that's when you want to either to improve what you're doing now, or reassess if you missed any other possible etiologies. Again, some of the non-pharmacologic therapies, I like to talk about these again since they're important and usually not talked about. But providing a comfortable but stimulating environment is important. And a lot of that requires patient and caregiver education. If you have a lot of turnover in the facility that your medical director at, or at that, then you need to provide good education to the nursing assistants. So again, your program's only as strong as all the members in your team. So you've got to identify at all levels that there are non-pharmacologic approaches, as well as social interaction groups, appropriate cohorts in certain areas as well. Again, for depression, try recreation, assess physical health etiologies, reduce aversive stimuli, and psychosocial support and counseling. A lot of times that early on is very important. And on Parkinson's patients especially, they're very prone to, you really need to sometimes optimize their dopaminergic, I can't say that word for the life of me, management before you really start treating, because a lot of times they will show that they need assistance in tuning that area up by having other symptoms such as depression or other etiologies. And then you consider antidepressant when they've at least had 2 weeks of duration that results in great distress or features greater than 2 months that start the behavioral environmental interventions. And again, it's important that you not only monitor this, but you document it, because especially if you're in a long-term care facility, when you have surveyors come through, they're going to really be looking at this. And OBRA really stands as Omnibus Reconciliation Act for History for the Fellows. It was passed in '87, and it was mostly because Congress were getting reports that elders in nursing homes were over-medicated and tied down. So they came up with rules that basically met regulations for most of the common accepted medications, and saying that they wanted accepted indications for particular types of medications. You had to show that. You also had to use typical doses and duration of therapy, methods for monitoring toxicity, and indications for dose reduction and time frames. So they basically set up an early standardization or standard of plan for many of these medications that were basically being used as chemical restraints. And again, they also say use only on patients that exhibit symptoms that impair functioning to themselves or others. Agitated behavior in itself documented is not a warrant chemical restraint. You really have to, again, document and show that the person is really aggressive, interfering with care, or harm to themselves or others, really, before you just start a medication. And we take that seriously. When I go down and when we inspect other facilities, we really do look for that. And and you make sure that the approved diagnoses and symptoms are clearly written as well, because that has to be part of it. Now, psychoses, we use the term a lot. It's for a lot of different things, but really it's an impaired connection to reality, or an auditory or visual hallucination or delusion. And it's really a symptom again. It's not a final diagnosis. And then your differential diagnosis is even a person in delirium or chronic psychotic disorders will have psychoses. But other things that some of our dementia patients can also be mistaken inappropriately for psychosis. You know, they're a thought that someone has stolen something from their room, house is not home, their mother is waiting. You got to think of their memory disorder where they're being placed. That's part of their disease process and not necessarily a true psychosis state for them. It's part of and then like caregiver being an imposter or the mate being unfaithful. It's again part of the disease process and not necessarily considered. Not all delusions are psychotic in nature. Now, conventional antipsychotic agents, again, I want to say that these are all off-label. None of them are approved for agitation or behavioral or psychological aspects of dementia patients, especially in the elderly. So we have limited efficacy and substantial toxicity is what we know with the conventional. And that's typically like haloperidol being the agent that most likely is stated with the conventionals. It's associated with increased risk of falls, cardiac toxicity, and also EPS symptoms with Parkinsonism, akathisia, and tardive dyskinesias. And you can see with the conventionals, as after 3 years of continued therapy, as many as 63% of patients show signs of tardive dyskinesia. Now, the efficacy of atypicals in dementia, again, off some of the meta-analyses, because that's about the best level of evidence we really have at this point, is that they do show that the particular agents that have been looked at the most is risperidone, just because it's been around longer. There are some other agents. But they have found that risperidone and aripiprazole, but not olanzapine, have been efficacious at decreasing behavior on efficacy scales. The lack of evidence against quetiapine, because of different selection criteria in this particular meta-analyses, prevented them from being pro or con on the use of quetiapine in this particular one. Response rates weren't, so basically, but the bad thing was dropout rates were as high as 1/3 for all groups. Adverse events that were common were somnolence, urinary tract, urinary incontinence, UTIs, and cognitive skills actually worsened on some of the medications. So, and it varied at different doses of the same medications. So, when we talk about atypical antipsychotics, you've got basically the grandfather, clozapine, that shouldn't be used unless you're really familiar with the drug, and we'll go into that. And then risperidone, olanzapine, quetiapine, zisperdone, and aripiprazole, I can't say that. And this is the OBRA guidelines, actually, and they actually regulate what your initial dose should be for geriatrics, your typical range, and actually your maximum on your drugs. And actually they're very upfront. If there's no evidence at all, then they usually put unknown. And so whenever the surveyors go through. And you actually have to show that you've had documented justification with diagnosis and symptoms, and that you've actually tried to withdraw the agent over a couple of times a year on average, and that they needed to require it. Now, how to choose one among the atypicals, mostly a lot of times with like many other drugs in the same classes, we look at comparisons for side effects. Are you going to be able to get someone to be able to be compliant with the medication? Now with clozapine, it's very high on the sedative scale. 39 to 46% had sedation. Almost 27% had dizziness. They had reflex tachycardia in 25%, hypotension in 9%. And what it was really concerned for that gets most people is the agranulocytosis, with 32% of those cases, when it does occur, being fatal. So you really have to monitor those patients. They're also now, in the last few years, coming out with cases of myocarditis and cardiomyopathy, as well as known significant weight gain. We're talking like 5 kilos of weight gain over a year's period of time plus on therapy. So that's why they start. And then also now with the class-associated stroke risk, cerebrovascular event rate, and that's a whole class event. If they started off with particular agents, but now I've extended that black box warning to all. So when you look at agents, you really want to know, A, are you really setting your patient up for failure for side effects? And then is the person at a place like a long-term nursing home, are you going to be able to do tests that are required for this particular agent? Such as like quetiapine, it's not well known, but you need to do eye exams usually at initiation at 1 month and every 6 months due to a high rate of ocular lens inclusion defects with that particular medication. And then there's also worsening in cholesterol and triglycerides. Typo here, I apologize. So you really need to know your drug if you're going to choose one, and you need to be careful with it. Some of those side effects, I won't go into this detail, but it's really the binding profiles on the different, their affinity for blockers of receptors. And as you can see, like Haldol or haloperidol rates is a lot higher affinity for D2 per se than clozapine or quetiapine, and you can see some of the effects of blockade. So some of them are positive and some of them are negative. So depending on how tightly, even within a class, there's a lot of difference on binding at the different receptors. Now with clozapine, that scares a lot of people, and it's appropriate. You need to be knowing what you're doing with it. It's used rarely because the agranulocytosis occurs and is as high as 2%, and that requires a baseline CBC and an ANC, and then requires weekly CBCs for the first 18 weeks. And then after that, you have to check it at least once a month on that. So it requires, you have to have someone in a setting. Not only do you know what you need to be doing, you need to know what you're doing with the drug, but also have a patient that is compliant or in a setting that can have the required monitoring for this drug once it's prescribed. It also has a rate of myocarditis, cardiomyopathy, and the seizures when used in high doses up to 5%. Patients that may benefit, though, is it does salvage about 30 to 50% of patients that are previously refractory to high doses of haloperidol. So there are a subclass of patients, but the reason why it's not used is, again, it needs to be used by physicians who are comfortable and trained with its use and have the proper setting to properly monitor it. Now, the other study, large study with risperidone is psychosis subscale with using the Behave-AD scale. And as you can see, it was dose effect before it reached significance. It was P of 0.008, 0.005 at 1 milligram, and then it actually decreased once you got to 2 milligrams, but it also was dose recognized cause of symptoms once you got above 1 milligram as well. So you want to know not only the medication, be comfortable with the side effects, but also know that higher dose does not always mean a better profile on your psychoses, and actually can cause more of a side effects in the persons. And then also, again, is your EPS side effects can be as high as 21.2% once you go from 1 to 2 milligrams. And then as you saw on the Behave scale, actually you actually decreased on its ability to help. And olanzapine, again, this is off-label, I must say, at 5 milligrams was actually a better improvement from baseline than once you got to 10 and 15 milligrams. And longer term side effects were worse at the higher. So not only the drug, again, know the dose. Now in Parkinson's, it's a little different in the sense that consensus on the practice parameter by neurology in 2006 recognized that quetiapine was a better choice than the other drugs when it was Parkinson's patients or even a Lewy body-based type dementia, because it actually was found to improve psychosis without worsening motor function. And they actually went as far as saying that the level of evidence was to not use olanzapine because it had been shown to does not improve psychosis and does worsen motor function. So a lot of people went to using that agent on like everybody because they knew at least if they missed someone that might be prone to Parkinsonism or Lewy body, then they wouldn't be worsening them. But again, when you're in an area without a lot of evidence-based, the best you can do is like to bring it together and understand what you're using a drug for. Trends in the use in long-term care settings, though, 62% of residents in nursing home settings manifest significant associated symptoms with cognitive impairment. Of those behaviors in this study, 18.2% were treated with antipsychotics, 11% were atypicals, and 6.8% were conventional. And of those, just the particular agents, partly because, again, this drug has been out longer than the others, but it still has the same black box warning with the same CVA risks as the others. Now, the risk of death with atypicals and dementia, again, not only knowing that it increases death, but you also have to know that whenever you counsel patients, especially when it comes to more difficult to measure things such as quality of life, you need to know what they're really talking about. So death occurred more among drug randomized patients. This was a study that pooled together multiple studies with multiple agents, and it was a 3.5 versus 2.3% death rate among patients who had been randomized to the drug, so an odds ratio of 1.54. And there was actually in this one no evidence for differential risk for individual drug severity, dementia, or sample selection or diagnosis. And for every 9 to 25 patients who benefited from a treatment, there may be one death associated, is what they had done from their calculations. So you're kind of like, does that help me? Does that hurt me? And then but when you compare it to the other agents, the conventional tape agents, which we had been considered the gold standard for both delirium and other agitation effects, they've done a study with almost 23,000 elders, and they were over the age of 65, and they found conventional antipsychotics had a 37% higher and dose-dependent risk of death in short term than those with atypical agents. They had an odds ratio of 1.27 to 1.56. So there's actually a greater risk after the initiation of treatment when using higher doses. So when you look at the agent, yes, it's not perfect, but when you look at what's been considered used as some typical gold standard, then you get it in perspective as to what your choice would be in another class. And again, breaking it down by agent, when they did individual studies on the cerebrovascular events, adverse events, is 3.8% versus 1.5 in risperidone, 1.3 to 0.4 in olanzapine, aripiprazole 1.3. So as you can see, yes, it's a doubling in significance, but some of them are even within a class, as we've found with many other drugs, have other things. Now, recommended monitoring protocols for atypical antipsychotics, we don't really talk about this much, but actually when you start looking at the diabetes literature and you start talking there, this is a consensus report basically by the different associations, and they recommend that an atypical antipsychotic, you basically do a full check at baseline, and then even at 12 weeks, you basically reassess, because that's when you start seeing large weight gains, and then you can start seeing glucose changes, both high and especially in patients who weren't previously diagnosed with diabetes. And also your fasting lipid panel can be off by as much as 10 to 20% in that time frame. And then they go on to annually. So now that we're starting to use these agents for longer periods of times, we also need to know. So what is a clinician really to do? You need to really avoid any reaction one way or the other. You got to take in perspective of your risks. And with anything, it basically boils down to a careful informed consent with the guardian. If this is the one agent that's keeping them at home with their family, or if this is the one agent that keeps them from hurting themselves, then again, informed consent, and we do that with any other drugs that we pretty well use with patients, and should be viewed as such and documented as such. And again, risk perspective, if you look at the atypicals, the increased risk mortality was relative risk of 1.5, whereas typicals were 2.1. Well, what about physical restraints? They had an increased fall risk of 1.65, increased recurrent falls risk in those folks of 2.46. We all know how that goes. So whenever you say, well, we don't want to use atypicals, you also need to know for the right patients and for what percentage of risk that you have with your alternatives. And when keeping in mind on another area that now has been in the, a lot or battered around, again, whenever you counsel women on their use of postmenopausal HRT, again, it's appropriate telling them their risks versus benefits and making an informed decision, both at their level. So I just want to kind of put it in perspective of the risks. Now, when you talk about depression, of course, they are label indications for antidepressants for depression, but when you're talking about the depressive symptoms of dementia, it's not specific. But the agents that are becoming more common are actually the SSRIs and SNRIs, mostly because of the less anticholinergic side effects, like the traditional TCAs that would have. And again, you want to start slow, and some of they have additional, like sertraline tends to have more anxiolytic activities, and citalopram tends to have less sedation or lower sedation, whereas sertraline none. Whereas once you get to mirtazapine, sometimes you can use these side effects to customize to your particular patient. Like if you give it at nighttime, and this particular patient is more of a nighttime habit problems, then you might use that more. So some people use these to their benefit, knowing if they use it correctly, then that's fine. But a lot of people still are staying away from the TCAs. Now, where we start really getting in trouble a lot of times is when the patients are displaying, the frontal lobe impairment syndromes. A lot of times recognized as secondary mania, and it's basically your poor impulse control, disinhibition, when they're episodically physical aggressive, perseveration, restless grabbing, react strongly. And again, these are the ones that are highly institutionalized rate patients, that this is something that usually keeps them from being able to stay at home. Well, the first line, again, this is off-label. First line mood stabilizers to treat manic-like behavior or anticonvulsants. The ones that are becoming more used are valproate and carbamazepine. Carbamazepine has a longer data search, you might say, but they have more worrisome side effect profile in general than people on valproate. So some people are starting to lean more towards valproate, and we'll go into some studies on that. And atypical antipsychotics used in mania with the stabilization of mood, especially in frontal lobe type symptoms, again, are olanzapine, quetiapine, risperidone, and ziprasidone. And again, remember, quetiapine is more the choice in Parkinson's patients, or especially Lewy body type patients. And then the second line mood stabilizers, they've been in the literature, but they really have poorly tolerated or limited data, such as lithium, gabapentin, topiramate, and other conventional antipsychotics. And at one point they were even using, sometimes for physical aggression, they were trying to beta block them or even use alpha agonists. But the literature risk versus benefit in those areas are pretty poor. Now for the studies on valproate in the elderly for mania and depression, again off-label, it was a double-blind, placebo-controlled randomized trial of nursing home residents that met criteria for secondary mania, and it was found to be significantly improvement on the Mansfield, Cohen-Mansfield agitation improvement score, but it was suspended due to side effects, primarily sedation. So it's by no means a cure-all, and you've got to be very careful in your selection, especially in liver disease, whenever you start using the anticonvulsants. Now, the side effects with this can include somnolence, thrombocytopenia, weight gain, hair changes, tremors, hepatotoxicity, and pancreatitis, but pancreatitis is more rare. But you do need to monitor blood levels on this. You do need to monitor CBC blood levels and LFTs for this particular agent, because you can't, again, you've got to choose the drug for your patient. Not all patients are ideal patients, in the sense you might not be able to get blood draw on someone that's at home or be able to monitor them for side effects. Now back to carbamazepine, it's chemically related to TCAs, is how they hypothesize that it works in mania. But it's absorbed slowly in the GI tract and has a long half-life. It was helpful in verbal and physical aggression, but it had many adverse effects, primarily in ataxia and dizziness. And 2 positive studies showed consistent benefit, but again, it was really high concerns for side effects and drug-drug interactions, because again, most of these patients are taking more than one drug. So we're starting to branch off into these agents, but we're finding out that we really have to know what we're doing and looking for in these particular agents, because in young people that are using them for true anticonvulsants are a different population than on an elderly person on an off-label indication. You need to monitor them much more frequently. In fact, they want CBC monthly for 2 months and then every 6 months thereafter. And again, it does have a black box warning for drug-induced bone marrow suppression. If they're on certain agents such as theophylline and warfarin, that increases the metabolism, and its absorption is decreased when given through NG feedings. So again, know your patient, know how you're giving the drug, know your drugs, and know the doses and what you need to monitor. Now, managing sleep disturbances, which are common, especially in long-term care, first thing you want to do is improve sleep hygiene, whether that be a regular bedtime, whether that be use of bright light therapy in the sense of trying circadian rhythm interventions where they know it's daylight, and then common things of music, anything like that. You want to use those first, music relaxation therapy. And if the above do not succeed, they consider usually using the use of trazodone, mirtazapine, or zolpidem. Again, with the trazodone and mirtazapine, it's never really, again, they're definitely off-label, whereas at least zolpidem is an agent that's approved for insomnia. So it's a little less off-label, although it's in a population that was not studied with the drug when the drug went through FDA clearance. So I like to just bring that up. But you definitely want to avoid benzos and antihistamines, because you're going to get a manic and not a very pretty response a lot of times, especially from the anticholinergic side effects from the Benadryl. Same way with delirium. If you use Benadryl for sleep in any of the elderly patients, inpatient, you have a high risk of them having a paradoxical reaction of delirium and agitation. So not all people get sleepy from Benadryl. There are some people who get wired, basically. So you want to avoid the benzos, which were commonly used in the past. Now, when it comes to hypersexuality, sometimes, especially in male patients, they were using androgens for male, but again, they got to get a part of that is risk benefits with the provider about the power of attorney about what these are, because they do have side effects. But yet they were using them sometimes in hypersexual or aggressive men, especially whenever they have frontal lobe disinhibition with dementia. And again, benzos, minimal efficacy data, it's sedating. It further inhibits learning and memory, so if you already have a dementia with a memory problem, now you're going to make it worse. And it does have a high rate of falls, and actually sometimes has paradoxical disinhibition on top of what they already have. So sometimes you're putting kerosene on fire if you're using benzodiazepines in those type of symptoms. Now, the cholinergic agents that we use for dementia a lot of times actually have some effects themselves in neuropsychiatric effects. What's strange is we think of these agents more with Alzheimer's, but some of the patients who benefit the most are actually Lewy body dementia patients. The key effects, especially with them, is they decrease psychosis, visual hallucinations, decreased apathy, decreased agitation, but occasional increase, decrease anxiety and depression. So it actually, this study was done with donepezil, and it was a treatment that showed improvement in neuropsychiatric symptoms in a randomized study. So sometimes the agents that we actually use for dementia, if they're not being used for some reason in a patient, just by prescribing them we can. And we may associate with these agents more with Alzheimer's, but actually again the patients who benefit the most are particularly the Lewy body patients, or even Parkinson's patients with concomitant dementia. So this is the way I kind of like, this is an algorithm I borrowed, the algorithm for managing behaviors. First you want to describe the behavior, see if there's a cause. Again, just like delirium, you don't want to just treat the symptom, you want to find out what's causing it, and that's your ultimate treatment, is to treat what's causing it. And then you want to see if you can do a treatment mostly with just modifiable environmental or caregiver factors, and if that's possible, then you stay there and then reassess. If not, you go to behavioral response to drug therapy. That's when you start, after you've tried the conservative measures, then you go into, and then you want to specifically, if they look like a depressed patient, you want to use more of an antidepressant. If you see more of a psychosis or a frontal lobe, then you want to use more of the atypical antipsychotics, but again, only with upfront approval by the POA with known risk versus benefits. And also refer. It is, also checking with colleagues as well, because this is a tough area. It's not the prettiest talk sometimes because it's not a safe talk, but it is one that really heavily affects our population in geriatrics. And it's not one that we understand well, and a lot of times you have to just kind of like learn on the streets. So at least the best thing we can do at this point is to bring what is known, what has been studied and the best studies that are available, and then have open colleague discussions with these, and an open interaction with the POA's power of attorneys about risk versus benefits in each patient. In summary, distress behaviors are clues to diagnoses, not a diagnosis of themselves. Unless urgent, the complete assessment determines the working diagnosis, not just the symptoms. And first, you want to use the non-pharmacologic interventions. Consider side effects and tolerability in all medication choices, not just the ones you're using for the behavior, but also check your medications to make sure one of those aren't potentially causing the behavior itself. And sometimes you've got to make sure that there's not going to be a potential drug-drug interaction once they're on it. And also treatment goals to enhance quality of life in patient are your ultimate. And again, the hardest area of this and what made it kind of an unsafe topic was that most of them are non-FDA approved indications and they require informed consent. But again, it's something that can affect as many as 40% of all Alzheimer's patients. And again, if that's something that precludes them from staying at home and being institutionalized, it's something very important to our patients. So we need to at least know the evidence that is out there, whether it not be perfect level evidence-based medicine at this point yet or not. We can't completely ignore it. So now I'd like to have it more interactive. Does anyone else have any comments, Dr. Cheto?
I had a couple of questions.
Yes,
I
ma'am.
like the algorithm. Where did that come from?
Actually, I'll get the source. I think I have it later in my reference, but I was gonna. It's one of the behavioral guidelines for dementia.
And have you seen, looking at nursing homes, and some written consents that people are using for these? And
Yeah.
I'd like to see some examples of those sometime, just because.
Actually,
sometimes
yeah.
medical legal issues.
When we inspect, like the state veterans homes, when we go in there and I do a chart check, there's actually a consent form just like doing a procedure, and for any chemical restraint. And it has to be specifically the agent, and the dose has to be on each time.
And see, normally we don't actually prescribe these as restraints.
I know.
We prescribe them for specific symptoms, and we don't
I know. Well, part of it,
in our outpatients. So
yeah, we're and part of it's the regulatory mechanism, the CMS using OBRA in the long-term care setting. And that's why I thought this was an important subject for the fellows, because if you become a medical director in a long-term care facility, this is something that you better know, you better be familiar with, because you really, an outpatient and inpatient, you have totally different arrangements where you have a lot of free range. But if you're in a long-term care setting or someone that goes back to one from being inpatient, you've got to make sure that you're aware of OBRA and its regulations. And that's why I thought this was a good subject for for teaching, in the sense of, it's an environment that we're a little bit free from inpatient, but yet when you get on the outside, it's something you definitely get to know.
Are you aware of consenting issues on inpatients? Because we use this very, very frequently for joint periods of time.
Yeah.
And I'm not aware of any.
No, I mean the standard so far at this point hasn't been in the inpatient under Joint Commission. They use a little bit different of a survey mechanisms, and we haven't been forced. I'm familiar both with Joint Commission and CMS, and they're different regulations for either depending on the setting they're in. But inpatient for Joint Commission, they're really not as regulatory on the use of antipsychotics, because they're used to it being more in the content of it is label use med in the right patients. So just by a medicine being used is not going to necessarily raise a flag. Whereas on the outside in a long-term care facility, a use of this medication, regardless of the diagnosis, is going to raise a flag. So I think part of it's just the regulatory has really made the separation of the two worlds. But depending on where you practice when you get out of fellowship, is important to be aware of those. Any questions or interactions or experience from anyone? It's a tough area. Go ahead.
As of right now, what's your experience with the regulatory mechanisms to treat hospice patients for whom, of course, for a variety of symptoms, including, some completely unrelated to delirium, things which I'm going to put in the trash can diagnosis of delirium. We use typically antipsychotics, and it's the indications are a little bit different. I mean, I'm not talking necessarily nausea or vomiting.
Yeah.
But, the indications are different. We tend to treat a little bit more non-specifically, a little bit more, without a complete overview. It's just intractable vomit by a person who seems to have that look in their eye, or seems to be having that. Where's right now the understanding of the regulators and the people who do the inspections regarding the fact that, you know, in the final weeks of life,
Mhm.
you're going to have these symptoms.
Mhm.
Do they have an understanding? Are
They-
nursing homes getting in trouble with dying patients?
Yeah, and that's come in just the last several years. You know, with hospice being a component of, you know, traditionally you had separate hospice and you had long term. Now we're having home hospice, you know, rounding in nursing homes, and actually they do somewhat loosen some of the regulatory standards usually for hospice patients. Now, it depends. Is it necessarily standardized? No, and I think that's part of the problem, because again, their system is set up. If this drug is used, it sends up a flag, and then you have to justify it based on your diagnosis. But ultimately, on like inpatient or outpatient, I think it needs to be like if you do hormone replacement therapy after those studies, I almost had a informed consent in my records whenever a woman preferred to stay on it for symptom management purely. I would almost have that written in my chart, you know, patient was made aware of risk and management. I think that should be the same approach with the POA, in the sense that, again, all we can do is have informed and educated patients and let them know that there are risks and benefits, and let them ultimately make the decision. But as long as it's an informed decision and documented. Because as you know, unless it's documented, it didn't happen. But it's really, right now, it's just two different beasts that regulate different areas, whether you're an inpatient or whether you're long-term care. And that's the part of the problem, is they're not standardized between the two, and they're totally different. So depending whether this patient happens to be in the inpatient hospice or in the hospital right now, and their meds, when they get transferred over to long-term care, it has to be reviewed. And so it'll be deemed totally different. So it's totally not standardized right now. Short answer.
Sorry,
Yes, ma'am.
You mentioned something about withdraw the drug for at least a couple times a year.
Yes, ma'am.
How you do that in a home care setting? Just elaborate.
Yeah, and that's one of the arrangements. Sometimes you have to. In the military, what we had to do was actually do set up a home health visit, justify a home health visit for a blood draw on certain patients, which is hard to do. You got to really have to have a good setup with a social worker and home health agency that's willing to do that. And it's not intuitive in the sense that you're just sending them out there basically for that, but that's what it requires for them to be on the drug. Because sometimes by just having them come into the nightmare of just trying to have some of these patients with symptoms come in to get blood drawn is so disturbing enough to them to almost cause an admission sometimes. So a lot of times we have to use Band-Aid kind of situations, and sometimes it's home health visit to get the blood drawn.
For us, you make regular home visits. right?
Yeah, with
So you were talking about withdrawing the drug. Was that something to do with blood work, or
Actually,
it's more whether
yeah.
or not they need it?
Well, actually, those were in the long-term care environments. If you're in a nursing home, you have to prove that you have tried the patient at lower doses, and they required a higher dose again. Now, if they're anywhere else but a nursing home, the regulations are different.
Mm-hmm.
So again, those are if they happen to be a nursing home. For the fellows' benefits, I want to let them know that you have to prove that dose is the dose for that patient and to keep them managed, and you have to show that at least a couple times. And so it drives families nuts. My personal insight, my grandfather has vascular dementia. He's not a nice man sometimes without his atypical. And a few times a year, I get a phone call, and I realize that's the time I need to start talking as a family member, that we need to talk about the medications. So it's not fun, it's not fair, but they had good intentions, but sometimes it doesn't work well. Overall, it has decreased the number of chemical restraints and in the nursing homes by very significantly in the studies, though, since they have enacted open. So, they had good intentions, but as you know, some things with good intentions sometimes make things difficult. Or counterintuitive, at least. Yes, ma'am.
I have a question with non-pharmacological interventions first. I mean, I really like how you stress that.
Mm-hmm.
In reality,
Mhm.
how much do you see? Because a lot of times you get into the caregiver strike and the lack of support
Mhm.
for the caregiver.
Mhm.
So they, I think, may tend to default to the
Mhm.
medication. But I was wondering what you see in
And
your practice.
Especially, I had to deal with this a lot, especially when I was over at BAMC, because I had a lot of patients who had been on atypicals for a while. They were able to stay home, and then that black box warning came out. And then we had a overreaction somewhat in certain areas. I won't play. But then they freaked out basically once that warning came out, and they wanted to justify and take everybody off of them. And I literally had to bring in my patients and again just make an informed consent with every person. Because literally, if you have a really small wife trying to take care of the same aged elderly gentleman, and he's unmanageable without this drug and needs institutionalization. It's again just an informed decision, and in that environment without regulations checking me, I guess I'm able to do that. And again, I think with anything, whether it be hormone replacement therapy, whether it be anything, it's really an informed decision and documentation. Again, the key thorn being documentation too. So again, this is a tough area, and I could have picked a really safe, easy one, but I thought this was one that gives a lot of fellows and other people a lot of heartache. I could give a whole talk on non-pharmacologic interventions. There are a lot of them out there, and I used to do that. So back before we even really called it Alzheimer's and everything was organic brain syndrome, and I started off as an orderly. That's all we had was interventions, behavioral interventions. We called it something else at the time. But but you kind of learned it the hard way. So there are a lot of new approaches that really can be helpful, but they are labor intensive at times.
Yeah.
And you got to educate everybody at all levels for it to work. Cool. Thank you.
Thank you.